Okay, I think that we can start. I hope that during my introduction and short presentation of my introduction of our speakers today, people will continue to join us. I also wrote you in the chat that please, the participants can introduce themselves, their name, the country, to see that we are crossing all around Europe. And also, I will say it in the beginning because usually I forget at the end to wish all of us a happy New Year, a Merry Christmas, and everybody should enjoy in the coming holidays and vacations. So I will start with it in order not to forget it in the end. So my name is Shlomo Winker. I'm Wonka Europe president. I'm a family doctor from Israel, very active, very busy. And as you see, our panelists are also busy. Sarah Renas Bianco, she is now in her clinic, and she is the chair. She's leading our working party about policy advocacy. And thank you for organizing this meeting today. And also with us, our speaker, Minna Johansson. She is a primary care doctor at the Hellstad Healthcare Center in, I hope that I pronounced the name properly, Udevala. She is working as a clinician for the last 15 years. She is leading an international research network, the Global Center for Sustainable Health, focused on shaping a new appreciation of human financial and environmental resources in healthcare, and finding novel ways to make healthcare more sustainable for patients, also clinicians, health systems, societies, and our planet. So, Minna, the stage is yours. After her presentation, we will open the floor for discussion. The discussion will be in this way. You will put your questions on the Q&A, and Sarah and me will choose the best and most relevant questions to ask Minna. So, Minna, the stage is yours, and I hope and wish all of us a very interesting discussion today.
Many thanks, Shlomo, and many thanks, Sarah, for inviting me. It's really, really nice to be here. And today I'm going to talk about a topic that is very, very close to my heart and that I feel very passionate about. And that is how we can prioritize patients with the greatest care needs. I believe that this is one of the major challenges for medicine today. And I've chosen the undertitle, Is it time for us GPs to take the lead? I have no financial conflicts of interests. And the talk that I will give today is inspired by these amazing people and many more. So if you disagree with anything I say, you can blame them. So every day in my clinic, I feel like this, facing a tsunami of recommendations and guidelines and quality metrics, unable to follow more than a tiny fraction of them. And I believe that medicine is permeated by an extreme inability to prioritize. And that is all the way from primary research to evidence synthesis, to guidelines and quality metrics and other policy decisions, and the decisions that we make in the clinical consultations. Us primary care physicians, we would need to work 27 hours per day to follow the primary care guidelines that applies to our patients. So if we would follow guidelines and quality metrics, there will be massive opportunity costs that would substantially limit access to high-value care for the population. So there is a massive gap between what is expected of us and the time that we have to give care to care. And this gap, the result of that, the consequences, is that the care that we give becomes inefficient, because we don't spend the time on the interventions with the highest benefit, the greatest benefit. It also becomes unequal because we don't spend our time on the patients with the greatest care needs, and it leads to ethical stress and burnout amongst us clinicians. So who should we then prioritize? I think that for most of us working at the forefront of medicine, it's quite clear that we should prioritize those with severe symptoms instead of those with mild or no symptoms, those with large benefit from care, as opposed to those with small benefit from care, those with high risk to develop disease instead of those with low risk to develop disease, and disadvantaged groups instead of privileged groups. But in my daily work, I feel that the structures that I work under kind of forces me to prioritize in the opposite direction. So every day I feel frustrated that I have not spent my time on the patients with the greatest care needs and on the interventions with the greatest benefit. And in this context, it's not so strange that many of us say, like, go to the frontiers and demand more resources, that we say that we are under pressure and underfunded, we need more money and more people. But at the same time, most societies, most communities have actually never spent a greater proportion of our common resources on healthcare than we do today. These two graphs are from OECD. And in Sweden, healthcare spending has risen from 5% of GDP in the 70s to 7% of GDP in the 90s to 11 to 12% of GDP today. And that makes Sweden quite typical among high-income countries. And in the last 20 years, the number of doctors per capita in Sweden has increased by almost 50%. And that's also quite typical among high-income countries. In the OECD average is an increase of 33% in the number of doctors per capita in the last 20 years. So there's something in this equation that does not add up. In the last 20 years, we have become many, many more, and we have much more money, but still we feel every day that we are unable to do what is expected of us. This has some natural explanations, of course. We have aging populations that need more healthcare. Although I've read some really interesting analysis lately from the UK, for example, which says that these demographic changes are actually not the main driver for the increased costs of healthcare. Instead, it's probably the more advanced medical interventions. And some of these are, of course, very good. In the 70s, we had bed rest for 3 weeks when we had a myocardial infarction. Now, luckily, we have PCI. But something that we talk much less commonly about is the expansion of medical territory that has happened during the last decades. And that is what I will talk about, spend my time talk about today. And to understand this development, I have chosen to describe it in terms of the analogy of the public health river. I think many of you have heard about this before. There are many slightly different versions of the same concept. But in general, to summarize, the analogy is that downstream in the river of public health, we have people who need clinical care because they have symptoms of disease. So they are drowning and therefore needs our help. They need the healthcare's help. And this is where healthcare has traditionally spent most of our efforts. But the idea is that if we go upstream in the river of public health, we could prevent people from getting ill so that they don't need our care. For example, by treating cardiovascular disease risk factors or through screening. And if we go even further up in the river, we could change our patients' lifestyle, and that would make them healthier and not so that they never come downstream. And even further up in the river of public health is social determinants of health. So if we could improve the social circumstances for our patients, they would not need to go down to even come downstream and need our care. And this is very intuitive, and it makes sort of intuitive sense. But in this talk, I will argue that when we apply the individualistic and biomedical lens of medicine to the river of public health, then we end up in a lot of problems. So the first step upstream, prevention. This is an example of the problems that we might end up with. So this is a study from Norway, where they applied the European guidelines for cardiovascular disease prevention on the general population. And according to the guidelines, over 80% of all adults in Norway so that's the red, would need medical attention. They would need to see their GP to reduce their cardiovascular risk. And it's important to remember that this is one of the healthiest and most long-living populations in the whole world, where 80% is, according to the guidelines, in need of seeing their GP to reduce their cardiovascular risk. The authors of this study also estimated how many GPs it would take to follow only the guidelines on hypertension, and that would require 99 GPs per 100,000 adults only treating hypertension. But the problem was that in this region, there were only 87 GPs per 100,000 adults. So if we would follow the guidelines for hypertension, we would have to stop doing everything else. No follow-ups for people with suicidal thoughts, no surgeries of ingrown nails, no treatment of asthma or investigations for people with blood in their stools or other symptoms of cancer. So if we zoom out, it becomes obvious that if we want to reduce the cardiovascular risk for 80% of the general population, then patients who are sick will not have access to care. And this is obviously absurd. No sane person would want all GPs to stop everything else that they're doing and only treat hypertension their whole days. But why have we ended up in this? And this is the paradox with prevention of low-risk populations. So the study that I mentioned earlier that says that we would need to work 27 hours every day if we would follow the guidelines. Of these 27 hours, it's actually only 14 hours of those are spent on prevention of asymptomatic people. And actually only 9.4 hours would be spent on people with symptoms, acute or chronic symptoms. So following the guidelines for people with symptoms would be fairly manageable. But when we add prevention for asymptomatic people, the workload explodes. And why is this? How could this happen? So in the last decades or 50 years or so, the cutoffs for what is considered a disease and what is considered the responsibility of healthcare to deal with has been continuously lowered. And that is true for most risk factors and many diseases. It's true for hypertension, for hyperlipidemia, for osteoporosis, for asthma, COPD, and depression, anxiety, and so on. This is one of the latest examples from the US, where the cutoff what is considered hypertension has been lowered. So now everything above 120/80 is considered an elevated blood pressure. And everything above 130/90 is considered hypertension. And there might be some benefits of lowering the cutoff. But the problem is that the blood pressure, like most other risk factors and symptoms or conditions in the population, is normally distributed. So that means that there are very many people that are in the middle of the curve. So when we lower the cutoff from 140 to 130, there's an increase in the number of patients with more than 30%. There are simply many more patients that have a blood pressure between 130 and 140 than there are patients that have a blood pressure between 170 and 180. The other problem is that the benefits of treatment has the other distribution. So we benefit much more from reducing a blood pressure from 180 to 170 than we do from lowering a blood pressure from 140 to 130. So when we lower the cutoff and expand the eligible population a lot, then the opportunity costs might be, because our time is not infinite, it's finite. Then the consequence can be that we spend so much time on those with a low risk, closer to the middle of the distribution, that we don't have time to focus on those with the highest risk at the end of the curve. And this dynamic is true for most risk factors and conditions in the population. So we go even further upstream to behavior change. This is a study that I was involved in. We systematically reviewed all the guidelines from NICE. So that's the UK guideline organization, they do very, very good guidelines, I believe. We reviewed them systematically, all the lifestyle guidelines all the recommendations they did on lifestyle interventions. And we found that they had 379 recommendations for us clinicians to try to change our patients' lifestyle. A quarter of these recommendations applied to more than 25% of the general population. So a GP that is responsible for 2,000 people, for 500 of them, if they would follow the guidelines, they would have to give about 100 recommendations every year to 500 of them. Only 3% of these recommendations were supported by strong or moderate certainty evidence that they actually help people change behavior. And to follow all the recommendations would require more doctors of all specialities and 5 times as many nurses as currently working in the NHS. So if we would follow these guidelines, the healthcare system would collapse. And I actually think that if there's a silver lining to this, it's imagining all the neurosurgeons putting the scalpel on the shelf and only give lifestyle advice from 8 to 5 every day, 52 weeks a year. I think that's a little bit funny as a GP. Anyway, I also just shortly want to mention that we published in this autumn, in the Annals of Internal Medicine, going a little bit deeper into the methods issues that the guidelines were facing. So check it out if you're interested in this topic. Okay, so even further upstream, what is medicine's response to the fundamental health implications of social inequity? It's expanding medical territory even further. The new trend in the UK and also in Sweden and other countries is that we GPs should write prescriptions of that the patients should spend time in nature or sing in choirs or spend time with other people to become less lonely. The Royal College of General Practitioners in the UK write on their website that loneliness has become a public health epidemic, that it is as bad for health outcomes as obesity, and that GPs have a key role in identifying people who are lonely and also those who are at risk of becoming lonely. And I am, of course, not questioning that loneliness has a fundamental importance for the health of both individuals and public health. But I am questioning that I, as a GP, that the most effective and feasible strategies to decrease loneliness and social vulnerability in the population is that I target one individual at a time in my clinic. And if we zoom out, I think we can, and think about this from a more philosophical perspective, I think we could also consider whether, should we spend time in nature and spend time with other people and sing in a choir to reduce our cardiovascular risk? Or should we do it because that's what life is about? That's what brings meaning to life for many of us. It seems like a bad idea to me to think about everything in life in terms of medical risk reduction. Some time ago, I was at the hairdresser and I read one of these glossy magazines, and it said that sex lowers cholesterol. And I thought that was really funny because I can hardly imagine a more boring reason to have sex than the lipid lowering effect. And I think that that's like a symptom of that there's some things in life that medicine should just take a step back and leave outside the medical arena. Because we are actually not that good at preventing disease. The key determinants of health are not what happens within healthcare. Health is determined not so much by what doctors do for patients, but by arrangements in society, says Michael Marmot. And this is an example that exemplifies Michael Marmot's point. Screening for lung cancer is estimated to save about 12,000 of the 160,000 lung cancer deaths per year in the US. And this might very well make screening worth the effort. But in the same country, community-oriented interventions to decrease smoking is estimated to save more than 10 times as many lives. It is much cheaper and has a much less potential for harms, because screening for lung cancer causes unnecessary biopsies, etc. So the point I'm trying to make here is that the increased spending that we see in healthcare in most countries may actually not be beneficial for public health. Because every dollar or euro or krona that we spend on healthcare is a euro that we could spend on schools or the judiciary system or bicycle paths. And it's very likely that that would have more impact on public health than the stuff that we do in healthcare. So to summarize, in medicine, we try to prevent that people go downstream in the river of public health by trying to prevent disease through, for example, treating cardiovascular disease risk factors. We try to change the lifestyle of our patients, and we even try to improve social equity one patient at a time within our clinics. And this is intuitively good. It seems good. But when we apply the individualistic and biomedical lens of medicine to the river of public health, we cause flooding. So when medicine go upstream in the river of public health, we end up in a lot of problem. This is a study from Canada, where the authors estimated the magnitude of benefits from medical interventions. And they estimated that downstream, for people who have symptoms, our interventions are quite effective. So we only need to treat 5 to 7 people with symptoms, acute or chronic, to improve outcomes for one person. But when we go upstream, the number of patients that we need to treat to have benefit increases, 40 for CVD prevention and 1,000 for cancer screening. And for social screening and health promotion, they judged the NNT to be infinite, since they didn't find any real evidence for benefit. So, and these are, of course, very rough numbers. These are difficult estimates to make, so they shouldn't be interpreted as something exact. But the trend that the further upstream we go in the river of public health, the more people we need to treat to have benefit, and the proportion of the population also becomes bigger and bigger, because it's relatively few that are sick, but everyone can become sick. And the consequence of that is that downstream, we need to be quite few clinicians to care for all the people who are sick. But the further upstream we go, the more people we need to be working in healthcare to be able to implement all the recommendations. And this is why we need to work 27 hours every day to follow the guidelines. And I would argue that today we are so busy focusing our efforts upstream that we actually let the people who are downstream drown. Even in high resource settings, such as mine in Sweden, people with really, patients have problem accessing care for really basic care needs that would really have helped them. So how does this feel for patients? Patients are also facing the tsunami. 40% of patients with chronic conditions report that they feel overwhelmed and unable to sustain current investments of energy, time, and money in healthcare. This is a study that investigated how long time the patient had to talk before they are interrupted by the doctor. And that's on average 11 seconds. And I think that is one of the other fundamental problems in healthcare today. We are extremely poor at listening to patients, and that has massive consequences for patient safety and for effectiveness. And it's just a really bad idea to not listen to our patients carefully. This is a study, it's quite old, from 2005, but it's still very relevant, just as relevant today as it was 20 years ago. So these authors took a hypothetical 79-year-old woman with COPD, diabetes, osteoporosis, hypertension, and osteoarthritis. And as many of you working in the clinic know, this does not have to be a patient with very low function. It could be someone who's quite active. And they applied the guidelines to her, and following the guidelines would mean that she would need to take 12 different medications corresponding to 19 doses per day, 14 non-pharmacological interventions, and that was if all diet interventions was counted as one. The diet interventions were also contradicting, so it was physically impossible to follow all of them at the same time. I work with a professor at Mayo Clinic who's a diabetes doctor. Victor Montori is his name, and he sometimes talks about a patient he met who had a cardiogenic disease. So he had been told to not eat fat, and then he had diabetes, so he had been told not to eat carbs. And then he also had kidney disease, so he was told not to eat protein. So there was no source of calories left for him. And I think that's quite telling of what situation we put the patients in. So anyway, it was also several education and rehab visits and several visits to primary care and eye specialists every year. And this was the daily regimen for this woman. And I mean, this is a part-time job. I am a fairly energetic person, but I would never be able to follow this. And when our patients don't, we say that they have poor compliance or that they are non-compliant. And that is such a cruelty. This is a picture of my mother-in-law and my daughter and her little cousin when we were hiking in the Norwegian mountains. And I chose to put this here because I think that it's so important that every day we should remind ourselves that everything we do in medicine has one purpose and one purpose only, and that is to help our patients live the lives that they want to live. This is it's obvious, of course, but still, I feel that every day you have to be somewhat of a rebel to actually work like that. So, I think we all need to ask ourselves, when do I want to be prioritized? And to me, it's quite clear that I would much prefer to have an appointment at my GP when I have suicidal thoughts or when I have symptoms of cancer. And I think that goes for most of us, but we need to understand healthcare as a finite resource that we all share and need to be careful to prioritize. And that is, I think, the kind of thinking that we need to get into policy, into clinical care, and into the public. So to summarize, I argue that applying the individualistic lens of medicine to public health is inefficient, expensive, and harmful. And the very idea that preventive medicine will prevent most people from getting ill and thereby save lots of resources in the future is not supported by evidence. And I would even say that it's medical hubris. This is Icarus, the guy that had wings of wax. And when he, out of hubris, flew too close to the sun, they melted and he fell down on the earth and died. And I think the same thing is about to happen to us. So how can we then advance care without overwhelming the capacity of people, economies, and the planet? These are some of the solutions that is also often brought forward. Task exchange, make the nurses do the job instead of the doctors. And I think there's definitely potential in that. That's the way that we work in Sweden to a large degree. But there are shortages of all kinds of healthcare personnel, also nurses, and there is an apparent risk of fragmentization. Also, digital solutions and AI. I believe that AI will change the way we work and not in a foreseeable future. But so far, digital solutions and AI has actually not been shown to save clinician time. There's a lot of talk, but less action. Maybe we should let patients do the work. This is also very popular. And there's also a lot of potential in that. But many patients are already overwhelmed, and it's usually the patients that have the greatest need for healthcare that are most overwhelmed. So my conclusion is that yes, we can become more efficient through task exchange and digital innovations, but this is unlikely to solve the problem. For a sustainable healthcare, we must learn to prioritize. So how can we do that? I was very frustrated in my clinic. I felt really angry. And then I tried to use that anger in some kind of constructive path. So I ended up contacting Gordon Guyot and Victor Montori, who are professors in McMaster University and Mayo Clinic, and wrote this paper together with them, introducing the concept of time needed to treat. It was published in the BMJ last year. So in short, the TNT method is a method to facilitate for policymakers to consider clinician time as a finite resource that need to be carefully prioritized. But the intention is to increase the likelihood, the whole point with the TNT estimates is to increase the likelihood that we spend our time on the interventions with the greatest importance for the individual, and that we increase access to care for patients with the greatest care needs. So I will, with this example, I will try to illustrate what TNT is. And I also want to say that, of course, a method like TNT won't solve all of this. It's just, I think, one suggestion of one thing that we could do to become better at prioritizing and better at understanding opportunity costs. So this is, we estimated TNTs for a nice guideline that recommends all GPs to screen all our patients for physical inactivity using a questionnaire. And then for the about 40% that doesn't exercise enough, give them brief advice that would take about 10 minutes per patient on how to exercise more. And the systematic review underpinning this guideline did not find any evidence that that doing this intervention increased the cardiorespiratory fitness or any other objectively measured outcome. But they did see an increase in the self-reported physical activity, which is, of course, as we know, an outcome that is prone to bias. We all say that we exercise more than we do. We say that we eat less candy than we do, that we drink less whiskey than we do. At least I do. I lie about that all the time, and I think you're the same as me. Anyway, so we estimated that to implement this guideline, it would take 3 hours of GP time to increase the self-reported physical activity for one person. So you would have to screen a number of patients, and you would have to give advice to a number of patients for one person to increase their self-reported physical activity. This corresponds to 167 hours in a normal UK GP practice, which in turn corresponds to 15% of all the time that GPs have face-to-face with patients for all causes. So the idea is that guideline panels would, when they have this information, this is of course very rough numbers, so they shouldn't be interpreted as exact estimates. When they have this information, they could sort of zoom out and consider, is it really a good idea to ask GPs to spend 15% of all the time they have for patient care on this intervention that we actually don't have strong evidence that it actually improves patient important outcomes? And for me, as you might hear, I feel that that is a very bad idea, but that's a value judgment. So you can make different values in this. But the idea with TNT is to bring this question of opportunity costs up to the table, to sort of force guideline panels to consider, if we recommend this, what would GPs have to stop do in order to have time to do this instead? And this TNT thing got a lot of attention. I'm bragging a little bit now, but the editor-in-chief for BMJ, Kamran Abbasi, tweeted that this deserves to become one of the most influential articles ever published by the BMJ. And I was interviewed by the New York Times, which my boss at my healthcare center was so proud that her healthcare center was mentioned in the New York Times. I thought that was fun. There's also a lot of spin-off projects. It's already, the TNT method has already been implemented in several high-impact guidelines. There's a lot of research projects on TNT. It's been implemented in primary research as outcome and in frameworks, etc. So I'm really proud and happy about that. And I think I'm almost done now. I think that the reason that the TNT got so much attention, I was actually a bit surprised that it got so much attention. I believe that the main reason for that is that it's a slightly new way of communicating something that we GPs have tried to say and argue for a very long time. And I think that this is mainly about communication. No one wants inefficient and unequal care, but people don't understand the consequences of recommending much more than we have time to implement. So people don't understand the opportunity cost, the clinical opportunity costs. And I think that we GPs have a responsibility to communicate that much more clearly. Because what differs us is that at the core of our profession is a responsibility not only for the patient in front of us, but also for the patients that did not get a time. So we are every day painfully aware of the patients that needed to see us but did not get an appointment. And this responsibility for the whole population that we serve, that makes us different from the organ specialists. And we need to become better at communicating this to policymakers and the organ specialists. All this work is done under the Global Center for Sustainable Healthcare. This is our website. Please check it out if you're interested. And to summarize then, the way we currently practice medicine is unsustainable for patients, clinicians, health systems, societies, and the planet. And we need to identify sustainable solutions to healthcare's challenges, and that is solutions that advance care without overwhelming capacity. And finally, my last slide. I think that we GPs, we need to take the lead to prioritize patients with the greatest care needs, because we are the people that understand this. We are the experts on this. Of course, we need to do that with courage, but also with humility. Thank you. That was all I wanted to say today. Thank you for listening.
Thank you for the very interesting and brilliant lecture. I will start with my reflections while Sarah will start to collect the questions. And I presume that there will be many questions. So first of all, I have to say that this is the second time ever that Sweden came with TNT. The first one was Nobel, but that invented the TNT, and now another brilliant TNT coming directly from Sweden. I had to mention it because I don't know if you thought about this when you put this acronym. Anyway, I'm also a manager in the healthcare system, and I just can tell you that I'm a member of the reimbursement committee in Israel. And last year and this year again, we will be dealing with the technology that costs $2.5 million per one patient. It's gene therapy. So when we are talking about competing about resources, we have to know that there are many other competitors, not only us in our clinic, just to note. And also, but about the hubris that you said, it's a matter of expectations. It's not only clinicians are waiting that we will find a solution for any problem and people will live forever. This is also the expectation of the patient. So this journey should go together with the patients. They have to understand that we are not against them, that we are working together with them. Because otherwise we will end with a lot of malpractice suits, which is again a real problem, at least in my healthcare system, because if those recommendations are in the guidelines and the family doctor didn't give them to the patient, he can be suited in the future. So this is again, so this journey is not only in our clinic, it's the patients, it's the system around us, it's the patients, everybody. So
Yeah.
these were my reflections. If you can comment, and then Sarah will go on with questions.
Yeah, I mean, I fully agree. But I think that if we think about patient safety, for example, then patient safety measures usually recommend that we are much more thorough and do much more and follow the guidelines. But then you only think about one patient at a time. I mean, what's the biggest problem for patient safety? In most clinics, at least in mine, it's because we are so stressed that we don't have time to listen to the patient, that we don't have time to see the most important issues. So I think that, I mean, the most important measure to increase patient safety would be to prioritize. That's my view. So I think patient safety should be interested in prioritization. But anyway, I fully agree that it's about a cultural shift. So both the public, policymakers, politicians, and clinicians need to understand that healthcare is a finite resource that we all share and need to prioritize carefully. But it benefits everyone. And that's, I think, what we need to communicate. We all want access to care when we really need it, but we need to understand that if we demand an MRI when we have had pain in our foot for 2 days, then that means that when I really need an MRI, I will have to wait longer. Or when my father really needs an MRI, he will have to wait longer and his prognosis might worsen. So it's this understanding of the clinical opportunity cost, which I think is really important. And it could be argued that that will be very difficult to achieve in a system that is very like me, myself, and I. It's very individualistic in most of our countries, I think. But we have, in many countries, succeeded in the terms of antibiotic use. So when I started 15 years ago, it was difficult to convince people that they didn't need antibiotics for a viral infection. Now it's like kicking in an open door. People don't even want it when they need it. So, and I know that's different in different contexts, but what happened in Sweden, it's not because I have given advice to one patient at a time. It's a cultural change. People understand that antibiotics is a resource that we all need to be careful about. And that's the same for MRIs, for healthcare, for all healthcare resources. So, but thank you, Shlomo. I think we agree with each other.
Thank you, Minna. So we have at least 15 people who said thank you for your talk. So I think everybody was really interested in following. And we have several questions to ask. So one of the questions says, how can health policies be shifted to enable the provision of just-in-time care accessible anytime and anywhere? Who should be responsible for triaging patients requesting appointments to reduce the need of GP visits? Should be the role of nurses, auxiliary nurses, or other healthcare professionals? So how we can prioritize patients in real life when they want an appointment, and who should be the responsible to do that?
Well, I think it's a very difficult question that it's not one correct answer to. I mean, this is also, I think, a part of a cultural shift. So patients today, in my context, and I believe in many contexts around Europe and the world, patients has become is not accepting the historically paternalistic understanding of medicine, where the doctor just say what they need and they just accept it. And that's a very good thing. I mean, obviously, we need more patient engagement. Patients' autonomy needs to be respected much more, and patients need to have much more power over their healthcare. But that comes with responsibility. So I think we need to be able to keep these two lines of thoughts in our heads at the same time. We need to go away from the paternalism, but we need to also to understand healthcare as a resource that we all take responsibility for. So, and I think that is a cultural shift, but it is possible to get there. It's hard, but it is possible. And also, currently, we're in a very unsustainable healthcare system. People can't access care. People understand the frustration that they have problems accessing care. And they just need to make the connection that is because we do so much of low value and we don't prioritize. So if we can communicate that connection, the consequence, then I think people would be open to be more careful about the resources. But, and then another thing I want to say to that is that I think that in primary care, the key to a lot of this prioritization is relational continuity. So I've been at my healthcare center for 15 years. I've known my patient for 15 years. Some are very worried and want to see me very often. But after I met them a few times, it becomes much easier to say, okay, so I don't think doing this MRI is a good idea. And they, you know, it's about the the longitudinal relationship of care can reduce the unnecessary care and the unnecessary visits. That's, yeah. But there's no easy answer to that question. But I don't think that that means that we should give up. We are crucial in changing and in driving this change. And I think that you can see a lot of good examples of that happening, but it's, yeah. So I'm very optimistic.
Yeah, that's good. We need optimism and hope in primary care. So, you know, let's be the optimist doctors across Europe. And so we have also 2 more questions that I'm going to join in one question. It's about if this topic about prioritization is such an important topic for our colleagues who are working at the hospital, and also how we can, you know, be protective of malpractice in case we are not following the guidelines and something wrong happens to the patients. So more or less, where is the line to do this kind of prioritization, and how we can work together with our college of different specialties to provide this kind of care?
So I think that, I think that the organ specialists are more interested in this than we might think. After the TNT publication, I've been invited to lots and lots of meetings for organ specialists. And I mean, they also see the problem. They also have long waiting lines to see them in many countries. And it's also, they also need this prioritization. So I think that it's, again, I think it's a matter of communication. So I think there's more momentum in that communication than we might believe. But of course, it's with humility, because I mean, we have our perspective and they have their perspective, and we need to respect each other in that. But one thing that I think is very important is that we need to speak with a little bit more confidence. There's a tendency that primary care physicians or GPs are a bit like, maybe we're not most read up. If we're on a guideline panels, maybe we are not most read up on the latest, you know, RCT on a specific issue. But that's not what we bring to the table. Our expertise is the generalist perspective. Our expertise is the opportunity costs. Our expertise is understanding the need of prioritization. So I think we should do that with a bit more confidence. And to do that, we need structures that help us with that communication. And TNT is one example. I think we need other structures in other areas too. But TNT is, I think, one way of communicating. So we can estimate TNT and then communicate with the organ specialist. So that's one thing. And then what was the organ specialist, and then what was the other?
The other question was about how we can prevent malpractice, or, you know, just to avoid some kind of mistakes or problems if we are doing this kind of prioritization, you know, who is going to take care of if something happens. Obviously, it's not going to be every single patient, but I think there is a fear that maybe we can miss something. So, you know, what can be our answer in this case?
I think the problem now is what happens is that we do it correct with the patient that is fortunate enough to be in front of us. And then we don't care about the care that people are missing out, that, you know, and that's, so, I mean, in total, the patient safety becomes much lower by not prioritizing. So it's the biggest problem of patient safety is our inability to prioritize. But so it's one thing what we can do as individual GPs, and I understand that that's hard. I understand that it's difficult. I mean, I feel that too. You're scared of what would happen, and if you don't do something, then you might end up. I can understand that. I also think that it's impossible to work like that. I mean, you can't work with that axe over your head. But anyway, I see that challenge. But I also think that we can become advocates. So we can try to advocate for the authorities working with patient safety and working with these issues in each context, in each country, to make them understand, again, about the communication, that this way I mean, no one can work 27 hours a day, so we have to break the guidelines. But now it's coincidental. So do they want it to be like of coincidence who gets care according to the guidelines or not? Or do they want that to be something that we have thought about carefully to prioritize those interventions with the greatest benefit and the patients with the greatest care needs? I think no one wants, and I think you see my point. We need to be, we can do something in our little context, but we also need to be advocates to change how we look at this from an authority perspective. Yeah.
So another question related with this is like how we can address the influence of pharmaceutical companies or patients association about also ChatGPT of patients who are checking for information. So how we can live with this tension with all these factors who are influencing patients and also doing this kind of prioritization, how we can make this change that you are promoting, and do you think it's going to be feasible to do it? How we can do that?
I mean, I don't think you have to be very paranoid to understand that pharma has like a massive influence on this. There's so much money to be made. So of course, that's a massive influence. And there's a lot of really important work going on these issues to have independent and transparent guideline panels, for example. And so I think, I mean, it's really strong forces pushing for more medicine and more low-value care. But the benefit that we have is that we have common sense on our side, which they don't. So I think we still have like a really big benefit from that. I mean, I'm not saying that it's easy, but I think that with pharma, it's just about being like pushing for transparency, pushing for independence in every step, not accepting guideline panels with conflicts of interest, for example. There's no reason to have someone that on a guideline panels that have gotten a lot of money from pharma. I'm not saying that the researchers that have that are bad researchers, absolutely not, but they should not decide what should be recommended. That's, I think, quite obvious. So again, it's just about, I think, it's so much that needs to be done, and it's easily to be overwhelmed and think, oh, nothing will happen. I mean, we can write one paper in the local public newspaper, and then we can write another one in a medical journal, and then we can take a stance when we are on a guideline panel, and we can create the platform that we all need to speak from. I think that we GPs, we need the platform to speak from, and that is, we are creating platforms to speak from. And I see that we are a quite young specialty in terms of academia, but we are getting further and further on that, and that also creates a platform. So I think we have a lot of opportunities moving forward with this.
So Minna, thank you so much. I think we more or less have answered all the questions. I want to tell you that somebody in the chat was sharing that we need a conference only about this topic. So maybe you can run a conference for all of us so we can listen and share experiences. And also somebody told us just to share some good experiences about GPs who were doing so. But I think your last answer was a good summary of how to address this topic and how to advocate to improve the care of our patients and to do a more common sense practice in our daily life. So thank you so much for your time. It has been, I think, a pleasure just to listen and to be inspired for your passion to improve the healthcare system. And so we are very honored just to listen to you. And I pass the mic to Shlomo to close the session.
Yes, I will finish it what I started. I think the journey is a journey of all of us together, not only the clinicians, but also patients, policymakers, stakeholders. Everybody have to understand it. Otherwise, when we will take the journey alone, we may lose. But together we can win.
Yeah.
And thank you for the brilliant presentation.
Thank you so much for all the great questions and comments. Thank you.
Thank you.
And good night. Bye-bye.
Good night, everyone.